need to achieve if we're going to have any success in reducing health inequities, which, as has been clearly shown in the presentations, in most countries are still increasing. Dr. Galvão showed how addressing social determinants links to many existing activities, the work on urbanization, work on health promotion, work on environmental health and climate change. All of those are linked to the agenda of achieving health equity. And it's not that this discourse of social determinants is new, but it's about considering what we're already doing, considering what we need to improve, what new capacities we need to and then considering how we can best help countries to move towards implementing the recommendations of the Commission, implementing other recommendations for related work within WHO, and moving forward on improving health inequities. So Michael showed a very clear example of how a country is moving towards reducing health inequities. In England, they now have a long history of documenting and monitoring health inequities, but as Sir Michael showed, there's still a long way to go to reduce health inequities, and this requires implementing health and all policies, engaging a range of stakeholders at global, national and municipal levels, engaging other sectors, identifying common targets, and then moving forward on action. Many other countries are also moving forward in a similar way. So, following that, and again, please do go to the presentations afterwards to perhaps help you to appreciate the presentations better given the technical difficulties. We now are going to move to our panel, and I'm going to ask each of our panelists to briefly comment in about 5 minutes on this issue of moving forward to action, moving forward from what we know we want to do to implementation and how we do it. And our first speaker is Dr. Jose Romero Teruel. He's a professor here at Georgetown University, and he's here to present in person and comment for about 5 minutes. Thank you.
Thank you, Mr. Chairman. Dr. Roses also for invitation to come here and to share with distinguished members of this panel and to meet again with several friends. After this presentation by Sir Michael Marmot and Dr. Galvão, Sir Marmot explained all the effort that has been done, and I think he represents several other professionals that have been trying to research and studies to demonstrate this relationship of forces, determinants, and the well-being of people. I think Dr. Galvão summarized briefly the efforts of PAHO to apply this knowledge in terms of programs that PAHO is developing. I was afraid because sometimes when we have ideas like determinants of health, besides all the effort in describing this, we have the tendency in the international agencies to create new programs. And instead of having an idea that permeates all the activities of the organization, to create a program that just talks about that. I think the presentation of Dr. Galvão explains that that's not happening with PAHO. I'm trying to be brief and just to go back to the basic, some ideas and my personal views of the idea of determinants of health. This woman that I present in this slide is not just to make a, yeah, I know, thank you very much. It's not just to make some ornament to the slide. For me, she is looking forward, see, how can we really apply for practical solutions of problems, and she's waiting. Not working. I am sure that here in this room, we don't have to go back to basic definitions of what is health, but just to remind that although since 1948 in the Constitution we have the idea that health is not only physical, it's mental and it's social, I increased the size of the font because people forget about the other two pillars, and particularly the word social. So health is also social for the well-being of people. And this word is so dangerous. For the past, many friends have been put in jail, or been tortured, or being just put out of the activities they were developing, studies they were developing because of the social issues. And today, the word still is a little dangerous, also in developed countries. Mr. Serge Michael, when he was presenting the report, Dr. Chan was just making emphasis in terms of that the access to health services is only one part of the ideas that the determinants are focusing. It's a little hard to control this because I touch the button trying to make it go faster, it does not move. Also from England, I had the privilege to spend some time with Thomas McKeown in Birmingham, and using the records that exist in England from past several years, he was showing that before all the technological developments, discovery of agents of infections, immunizations, and the technologies that we apply in healthcare, also the decrease in deaths have been happening for the different diseases. For me, that was very clear in the effort of McKeown in England to show this relationship, although this was lost in some of the papers and documents that he published from the past. So it looks like we have to still keep talking, discussing, doing studies, and making efforts to prove this relationship. Frederick Engels was commenting the studies made by Holland when he published a classification of houses in Manchester in 1830, showing that social class and mortality was related. And for me, it was very impacting, the statement made by Engels when he said, well, when you see someone killing a person, you call that a murder. But when we have several people dying because of social determinants, we just keep going on without paying too much attention. So he stated, this is a social murder. And was quite impacting the way he was his sensitiveness for this kind of problems. No? We have in the room here some people that have worked with the Health People 2010 in the United States, the program, and there was a graphic that was taken from WHO in there, and trying to classify the different determinants that are related with the well-being and the health of people. One of the boxes is healthcare, another one education, the things that we talk about. But although we know that, very easily later on next day we are just giving emphasis to healthcare, technologies, or even some people talking that we have education is the solution for everything. We forget about all the relationships that exist there. How to apply this knowledge in the activities that we develop? Some time ago, I had the opportunity to, a friend of mine from Bolivia was sending to me this mural that was painted by Solon Romero in the walls of the Ministry of Health. I don't know if you people can see this well here, but for me, he was representing the determinants of health and well-being in a kind of modern graphic like this one. The space that the painting uses for presenting his ideas signifies how much importance he gives to these things. These big hands here in the bottom, and some wheat and corn coming from here, is representing work and nutrition and food. Some people with the white guns are here also, and the tree that represents the security for people. And half of the painting is talk about peace and war. We also forget about the problems that we have today in the society and the relationship that we have between things. When we put these two things together, we see how we, the bureaucrats, we present ideas in our graphics, and how an artist represents the same idea. And I think he has much more success in providing the impact that we have. I already got advertised that I have 1 minute. I'll try to finish that very soon. We know the problems that we are faced today in our society: violence, war, child labor, and all the things that are happening today for affect almost half of the people in the planet. And although some of the dreams that we have developed from the past, like Health for All by the year 2000, Healthy People 2010, Millennium Goals, these are important milestones that we created for the work that we develop in the agencies, in international agencies, and organize our programs, and try to push. I'm trying to push here also. With Sir George, sometimes we were trying to motivate the religious organizations to get more involved in the health programs in the Americas. And when we look to the definition of health, we say, okay, human development is not that state of complete well-being, but also the capacity, resource. We had a long discussion because Sir George was insisting resource and I was saying capacity. So let's use both expressions here. For each person, how to participate in things is not the next one, please. This next one. For me, I came up with the idea of what I call the gladiator paradox, because it's very common from what we talks to the society or to the people. Exercise and good diet. Well, that was what the gladiator was doing, eating well and lots of exercise. But his options in life was kill or die. This is not to be healthy. The participation in society is the element that you are not being able to put together in our programs. That's not only to cure or to vaccinate or to prevent diseases. How we can help people to develop, to participate more in the activities. We have to, this is development. Next one, please. So when we look to our programs and people that we face in the activities that we develop in the countries, Dr. Roses was insisting very much the other day in terms of human security. Next one. And the concept of aid. Next one. Next one. Next one. No. Sorry, I think I cannot control this. What? Next one. Next one. Well, all right. These last two ones. Haiti came out now with an earthquake. It's already out of the newspapers. And but life continues there. We have new people being born. This is a friend, a Brazilian soldier, doing a delivery of a baby at this time in Haiti. I say, what is the problem? It's a challenge for us. Haiti has been there for so long, and we only discover the poverty and what exists in a neighbor after a big disaster, natural disaster. How to help this country to develop is a challenge. How can we apply all the knowledge of social determinants to solve the real problems that exist in the world? Next one. So when I see face, I say, they need aid. We think about donations. Let's change what we do with our programs, international organizations, just for humanitarian aid. We have really to work with the people in order to develop. So these people for me are asking that. Yes, aid. We need now, but can you help me to participate more, to develop, to organize? How we can use health programs? The knowledge that has been coming from studies developed by Sir Michael Marmot and the others. Ideas that we develop in our meetings. In this room here, so many ideas have been discussed in the last 30, 40 years that I have been seeing. Sitting here, I remember Orontes Avilés from Nicaragua, in 73, after the earthquake in Managua, a wave of suicide. And they have also dictatorship, Somoza. For me, at that point in time, I had all the elements that are in the definition of health. Physical, because they had the earthquake that destroyed the capital. Social, because they had a dictatorship, exploitation of the workers in the cotton plantation. And mental, because the stress of people suffering all this, the earthquake and the living conditions, led them to suicide. We develop activities there too, and I think someone else is going to talk about this later on. But how to impregnate the activities of this is what is to move to action, not to stay just repeating the discoveries of studies that we develop. Thank you very much.
Thank you, Professor Jose Romero Teruel, for those reflections on how addressing health inequities is about health development. But we really need to consider how we do that. It can't be just business as usual if we're going to address health inequities. And I'd now like to call on Sir George Allain, who of course needs no introduction, particularly in this room, the former director of the Pan American Health Organization and the director emeritus. And I'd like to ask Sir George to give us his thoughts on how we move to action.
Thanks very much. First of all, I'd like to congratulate Andalusia again on the 10th anniversary. I remember the start of this very well. I must tell Andalusia, it's one of the few emails I always read when it comes to my home, not even to my office. Although I must tell you that yesterday afternoon, I tried to look up something about it, and there was a power cut. And I always had to remind my friends that we live in a developing country. Thinking about equity here in PAHO is, as the famous philosopher Yogi Berra said, it's like deja vu all over again. So therefore I have to resist the temptation to enter the philosophical discourse on equity and justice and that kind of thing. So this morning I want to spend my 5 minutes thinking about how we in health move to action about these social determinants. Do we have any new solutions? Do we have any solutions that were not present when Dr. Horowitz spoke of this here in PAHO, about the kind of inequity that exists in the Americas? And I'd like to congratulate Michael Mahmoud really sincerely on bringing this to the fore and presenting the work in such a dynamic way. But I must also ask, as Michael has always said, we had the Black report, we had the Acheson report, we have the Mahmoud report. And between the Black and Acheson report, there was no change in inequity. Between the Acheson and the Mahmoud report, there's no change in the level of inequality. We have to ask ourselves, are the successive British governments venal? Why is it that they have not changed the situation? Why is it? And I think, I would hope that we are on a slightly different track now, and in 10 years' time, when there's another report that is produced, we will show that some suggestions made by Michael have taken root, and there has been some reduction in the inequity that exists in Britain. Mr. Chairman, I'd like to make 4 points comment. I'd like to suggest 4 possibilities for action. The first point I'd like to make is this, is the fundamental distinction that Michael always makes between the determinants of health or illness of the individual and those of the population. They are different things altogether. We must never get caught up in talking about inequity when we fail to realize that there's a difference. Hippocrates knew of the former, and Jeffrey Rose made us appreciate the latter, the terms of the differences between the individual and those of the population. The second point I wish to make, Mr. Chairman, is a critical distinction between addressing the health of individuals and the gradient that does exist, the gradient or hierarchy of health status, which is socially determined. And I have not found any population of primates in which there's not a hierarchy. There's a hierarchy in all populations of primates that I've encountered. I can't say I know them all, but those I've looked up. You have to ask yourself, if there's a social gradient in all primates, is it not inevitable that there'll be a gradient in health as well? That's a fundamental point. Is the gradient inevitable? That does not mean we can't improve the situation. That does not mean we can't flatten the gradient, but we have to ask ourselves, do we always have to have a gradient? And that is a question that Michael really does not address. The third point I'd make is this. How will we ensure that the decision makers and politicians take action on those social factors that determine health? Will they do it because of health, or will they do it because of legitimate welfare considerations? Is health a sufficiently powerful political argument to suggest that, for example, poverty alleviation measures are done because of increasing of health? And we have to ask ourselves whether optimizing the health of populations is a part of the utility function of politicians. The fourth point I'd make, Mr. Chairman, is this. And it's a repetition of the second point. Should we be modest and accept that we will never eliminate the gap? that the hierarchical gradient can be flattened or reduced, but never eliminated. Should we be modest in that regard? Because that modesty will lead us to kinds of action that will be different. If we regard closing the gap as an aspirational and not a real goal, we may not then run the same problem as we ran into when we dealt with Health for All by the year 2000. Now, the 4 points I'd make four recommendations for action, and I think of action in terms of a health agency. The action can be taken by a multitude of other actors, but I'm going to confine myself the actions I think should be taken by a health agency like WHO and PAHO. And number one is information, information, information. If we do not have the data, we cannot determine whether there's inequality, and we cannot determine whether there's inequity. And that is put third in the list of recommendations. From my view, that is number one. You're not going to get attention to inequity if you are not able to demonstrate what is upon the people, both individuals and populations. That is number one. And I would insist that the ability to help countries to establish the kinds of data systems, the kind of information systems to allow them to be clear where these inequalities exist is the most important action that health agencies can take. And I make no bones of saying it is the most important action that health agencies can take before they do anything else. The second point I would make is this for health agencies: the absolute necessity to demonstrate the efficiency of those programs, especially those that are supply-driven, which can eliminate some of the inequities. Some of the inequities can be eliminated. We can ensure that every child gets vaccinated. We can ensure that is within our competence to do it. We can eliminate inequity in that area. Theoretically, we can ensure that everybody has access to potable water. Many of these things that are supply-driven, we can ensure. And the things that are our knitting, we should be sure that our house is in order before we speak about what other people must do. So it's fundamental. The things that are within our competence as a health agency, we must do and do well. The third point I would make is this, Mr. Chairman, is it is not enough to be vacuous and say strength of the ministries of health. We've been saying it for time immemorial. Ministers of health also want to do good for their people. They also want to involve other sectors. But we have not been always most efficient in giving them the tools to make the case for health. There's a recent, I hate to refer to war, but General Petraeus was making the point about Afghanistan recently. He said the approach to Afghanistan is a whole of government approach. The approach to reducing inequity is a whole of government approach. And in the past, we referred to intersectoral collaboration as something a desideratum. And when we speak of intersectoral collaboration, the health sector has usually been a mendicant. The health sector has usually gone and said, please help us to improve health. Not so. We should not adopt that posture. We should not adopt a crouch posture when we deal with other sectors of government. And we have the tools to show the health sector what are the benefits for the society as a whole of investing in health. And we should be able to